Um, Good morning, everyone. We are really excited here to have Dr. William Whittier from Rush University Medical Center present to us on lupus nephritis. So Dr. Whittier is a professor of medicine at the Rush University Medical Center. As many of you may know, Rush is a huge center for GN, in particular lupus nephritis. Especially for the trainees in the audience, if you haven't, you should sign up for the renal biopsy rounds that they do on Thursday afternoons. I think they are very educational, but they are extremely fun because they put people on the spot as well. Let me know if you need a link. I'll send it to you later today. Bill has published a lot in GN and in lupus nephritis in particular. He's also the director of the ASN board review course in nephrology. So he's kind of someone who knows everything about everything. So we are delighted to have him. Go ahead, Bill.
It was a very nice introduction. Thank you. It's funny on X, I noticed that the advertisement actually had me as MD PhD, and I didn't catch it until someone notified me and said, "Oh my God, you're a PhD." And I thought, well, I'm not going to correct it now, but it's kind of like stolen valor. I felt I was really elevating my game just putting a PhD after me, but no, I'm not a PhD. I'm just an MD. But thanks for having me, Swap. It was a very nice introduction. So yeah, we're going to talk a little bit about lupus nephritis. Just to start off, I'd like to thank some of my colleagues who are my mentors, who really not only taught me a lot about lupus nephritis, but stimulated to me to specialize in a sort of a career in GN and work on, doing research and publications in lupus nephritis. And that's Ed Lewis, of course, who's passed away within the last year, and Steve Corbett and Roger Rodby. So I'd really like to thank them in advance because they really helped pave the way for us to even have some of these thoughts that we have about lupus and about lupus nephritis. And so what I want to talk about today is really a lot about the classification. I think the classification has morphed over time, and it's changed into something that it wasn't originally intended, and it's kind of gotten away from being a useful classification to a clinical nephrologist who wants to use a classification to help guide treatment. And I think there's some very simple, easy ways to try to fix the classification, and I hope we can move forward towards those for the future. I think not only just to help us understand how to treat, but also for the future, since new therapies are out there for lupus nephritis, and there's more therapies coming down the roadway. I think it's going to be important for us to classify the lesions correctly so that we know which therapies work, and maybe we will get some class-specific therapies in the future. So I want to talk a little bit about the history and how it was, and review why the classification needs to change, and review how the classification should change. And I really want to focus on class 3 and 4 because those are the biggies. And I think that if we just, in the end of it all, if we just learn to use the immunofluorescence and look at it in the right way, and also include the EM, I think that's going to improve the classification, and hopefully I can convince you of the same. So in 1974, the year of my birth, was the first iteration really of the WHO lupus nephritis classification. And a lot of this came about from Rush, actually, which our predecessors to even Ed Lewis was Kark and Murky, and they were instrumental in making the kidney biopsy a safe and successful procedure. And they used to go around biopsying basically everybody. I think that if you rounded, with Dr. Kark, he had one of the needles in his pocket at all time, and it could be anybody, and he was just going to stick that needle in somebody. And so what they did is they actually biopsied a lot of people with lupus, even if they didn't have any proteinuria or hematuria, and they just they found that there were some people who have lupus who don't have nephritis, and so they actually included that in the classification, which right now seems very strange. How can you have normal in a classification? But that was kind of the reason that they had done that, because they had done biopsies in patients with lupus and found no nephritis, and then mesangial, and then focal proliferative, and then diffuse proliferative, and then membranous. And the point here was that each of these is a different type of lupus nephritis, not a staging system. It doesn't go from normal to mesangial to focal to diffuse and then to membranous. That's a staging system where you would say 1 is good, 4 or 5 is worse than 2, and that's not what it was meant. It was each one of these was really a different cell type that was affected. Here's the mesangial, a different cell type possibly in 3, a different cell type possibly in 4, or a different pathogenesis, and a different pathogenesis for membranous. And that was kind of the original classification. In 1982, after the Paris meeting, Dr. Schwartz and Lewis, again, our predecessors, attended, they came up with a little bit more specific, and I'm focusing in really on class 3 and 4 because those are the lesions that we want to, that we care most about as nephrologists. And they introduced the active necrotizing lesion here as a 3. And then they kind of put 4 into those that would have more of diffuse or even global involvement, and that had extensive subendothelial deposits or immune aggregates. So this was the first sort of a separation of showing 3 would have possibly a different pathogenesis because it had active necrotizing lesions which did not have immune aggregates. And then this one was the one that had the extensive subendothelial deposits that everyone thinks about when they think about lupus nephritis. You think immune complexes that are circulating, they're getting into that subendothelial space, they're creating an enormous wire loop, and that's your prototypical classic immune complex lesion. And that was really meant to be the 4. And then the ISN RPS came along in 2004, and things got a little messy when it came to 3 and 4. And I think now, this was in 2004, and now 20 years later, everybody realizes that the little bit of a mess that it created, and they're working on trying to change this. But what they started to say, instead of the active segmental necrotizing lesion, keeping it as a 3, they said, well, if it's a focal lupus nephritis and not all the glomeruli are involved and it's less than 50%, let's keep the mild one as a 3. And then if it's all of the glomeruli or more than 50% are involved, we're going to make that diffuse. And so now it became, again, more of a staging system, whereas 3 was a mild variant of the same 4. And they took all these segmentals that were severe and they put them in as a 4, but they said, we're going to call it a 4S, meaning a 4 segmental, okay? So instead of keeping them as different pathogenesis, they sort of started lumping the severe versions of the 3 into the 4. And that was where a little bit of a problem kind of came about, because now we're mixing pathogenesises. Now, I'm not saying that we understand what the pathogenesis is. I'm just saying that the immunofluorescence can help guide us to what the pathogenesis may be, and this was sort of moving away from that. So, in summary, just on the 3s and 4s, and we had the segmental GN here as a 3, and the diffuse or even the global one as a 4. And diffuse means all the glomeruli, just as a definition, sorry. Global means the entire glomerulus. Segmental means one part of the glomerulus, and focal usually means less than 50%. And so those are the 4 important focal means less than 50% of glomeruli involved. Those 4 definitions are very important here. In 1985, we sort of introduced this necrotizing comment part where this was possibly a different pathogenesis. And then in 2004, they kind of mixed them up and put some of those segmental necrotizing ones in the diffuse and global category. So the problem really is it went from a classification scheme to a staging system, and that's kind of messy, because right now, if you asked a pathologist about a staging system, not a renal pathologist, but even about, let's say, cancers, well, a classification of leukemias would be that they're all different based on their cell types. We've got CLL, we've got CML, okay, and so, but you're still going to target that cell. If you're going to stage CLL, for example, you're still going to try to hit that CLL stage, but you may give different chemotherapy if it's more organs are involved. So if they have splenomegaly, or if they have some other, blasts in the system or something like that, then you're going to maybe give them more extensive chemotherapy, but it's still directed to that cell type. And so in the lupus nephritis classification, they started morphing it into away from pathogenesis, but more towards prognosis and severity. And that's, again, was a little bit of the mistake. So what their thought was for a long time was that at class 2, where you have mesangial deposits, that's the green here, the green little highlighter, some thought that if you go from a class 2, you're then going to become more of these deposits will come in here, and it might be a segmental lesion. And then when it gets really, really severe, they're all over the place, and it becomes a global lesion. And so some people thought that there really is this almost staging system, and then that's how the lupus was. But what was lost there is this segmental necrotizing lesion, is that can be independent of a progression from mesangial to whatever. And so it was recognized very early, even by Churg in 1982, when he wrote, this focal lupus nephritis is characterized by these focal segmental lesions of proliferation, inflammation, necrosis, and sclerosis. And it's uncertain whether the focal nephritis, as defined, is produced by the same immunologic mechanisms as the mesangial and the diffuse forms. So he was sort of pointing out here that it's very possible that this is a completely different lesion, that's a destructive lesion, that might cause renal failure, that we should think about might even eventually need to be treated differently, because they noticed that in some instances, the immune deposits were absent from the focal lesion. Okay, so if we go back to, well, I'll show you in a second. So he was saying more that this division really isn't clear cut, and that the class 3 designation should really be reserved for cases with this focal segmental necrotizing lesions. And I'm not here just to say because it was written this way in the past, it's the way it must be forever. That's not, it's actually the opposite of what I'm trying to say is that it was recognized early, but because it morphed away from that, we really lost some information as to how to characterize this, this segmental necrotizing lesion. That segmental necrotizing lesion, you may be very familiar with it as a nephropathologist or as a nephrologist, because usually we're using that terminology for what? ANCA vasculitis. You know, if you see a pauci-immune focal segmental necrotizing lesion, you're like, bang, checkmate, ANCA vasculitis, you move on, make sure the ANCAs are positive. If you see a segmental necrotizing lesion and the immunofluorescence is positive for IgA, then we call that IgA vasculitis. Okay, so what they're sort of getting here is that if you have a segmental necrotizing lesion and you only have background mesangial deposits in a full house pattern, those mesangial deposits are there similar to IgA, but the segmental necrotizing lesion represents a vasculitis. And so what they're getting at here is that the lesion of lupus vasculitis was completely lost. Okay, and that's why and they've gotten away from that completely. And no one really thinks about a pauci-immune lesion in lupus because it's the prototypical immune complex mediated disease. You think of wire loops, you think of all those other things, but this lesion is actually quite frequent in lupus nephritis. And you know, it may not be as rare or as common as the subendothelial deposits, but it's certainly there. And we think that it belongs in a class of its own. So there's some data now, and I'll share this with you, that a lot of the mesangial lesions, when they're rebiopsied later, actually go to the diffuse lesion and very rarely go to this, showing that there may be a pathogenesis here of progression between these two. Hopefully you can see my arrow here of mesangial going to diffuse. But that this segmental necrotizing lesion can have background mesangial deposits, but the area of destruction is still pauci-immune, meaning not subendothelial deposits here. The mesangials there, defining it as lupus, these would be full house mesangial lesions, but there's still this almost vasculitic type lesion, which is pauci-immune, causing destruction and may cause crescents. And this is what was basically been dropped out. So I wanted to focus in and blow that up so you can really see that the difference of what that may be. So why should the classification change? Well, I'm going to tell you a story about a different classification that changed, and it's not my story, but if you've ever heard Dr. Sethi or Fravenza tell it, it's quite compelling. And if you've ever followed the last 20 years of what has been done with MPGN, then you know that classifications can be improved on. So when I was a fellow, this was the worst classification in the world, which was everybody was really looking at the wrong things. They were looking at the EM and determining where those deposits were, and then they were putting this MPGN pattern of injury into categorized by where the EM deposits were. And what Sethi thought was, well, it's silly. I mean, right now, all we have is treatment of MPGN is aspirin and dipyridamol, right? And as you know now, MPGN is a diverse pattern of injury with multiple different disease states that can cause it. And why not use the immunofluorescence to help guide what the causes of that pattern of injury would be? And, you know, and so because you can have MPGN, lobular patterns, you know, double contours, all those things can be in the situation of immunofluorescence, which is negative. It could be immunofluorescence that's just positive for C3. It could be a full house immunofluorescence. It could be kappa or lambda predominant immunofluorescence. And so all of those different diverse patterns of injury can cause the same light microscopy features. And so the real difference is not where the deposits are on EM or what the light pattern of injury is, it's what the immunofluorescence shows. Because if it's really negative, then we think about a vascular sort of MPGN pattern. If it's C3 only, we think about C3GN. If it's kappa predominant, then we're going to hit the bone marrow and find out why there's these kappa light chains presented there causing the same pattern of injury. So he really changed the world. And now, because of the way MPGN has changed, we have very targeted therapies for the different types of MPGN. And what I'm saying is that we can sort of use the immunofluorescence in lupus to do some similar guidance of what our pathophysiology of lupus nephritis may be. So they're already working on classification. This was a editorial written, I think it was in 2009, and Charlie Jeanette was on it with Surya Session. And they recognized these issues with the 3 and the 4. The subdivisions of class 4S and 4G were included because of a study based on the collaborative study group out of Rush demonstrated a poor prognosis for the segmental lesion compared with the diffuse. Okay, that was Najafi. Now, another group confirmed this. It wasn't just the collaborative study group and Rush. So there's another study by Hill, which also raised the fact that these are different lesions caused by different pathogenesis. And they said, well, you know, we need further study here. We need to make sure that we include this lesion, make sure it's still a well-known lesion, that we can include it in the classifications, and that we're able to study on what the prognostic and the clinical relevance of it. So I was very excited when I read this. I was like, okay, they're recognizing this as a lesion. Hopefully it can stand on its own. Okay. And so they're also publishing on how the classification and why the classification should change. And so they said there's ongoing confusion of these class 3 and 4 lesions. And if you talk to any nephropathologist, if they get a lupus case, they immediately start to cringe because they know, oh my God, I got to get out my counter and I got to get out my measurement to measure which 50% of the tuft is involved and which is not. And I have to know if it's 7 out of 18 glomeruli, and I've got to say which ones are involved and not. And guess what? You tell the nephrologist, oh, there's 7 out of 18 involved, and 3 of those had more than 50%, and 12 of them had less than 50%. And guess what the nephrologist is going to do? Okay, I think we'll choose CellCept. Right? I mean, it's ridiculous. Like, well, maybe if there's a vasculitic lesion, we don't know how to treat that now, but if that's studied and we maybe treat that like a vasculitis versus the immune complex lesion might have completely different treatment, but we don't know that because all of these are lumped together now. Okay. And so they're recognizing that they're really, it's frustrating for the pathologist, it's frustrating for the clinical nephrologist, and it doesn't really mean any difference the current way that it is. Okay, if we have time, I'm going to get into podocytopathy, but I'm not sure we will, but I'm happy to talk about that. Well, I'm happy to talk about this stuff forever, but I may have to stop it at some point. So I really want to make sure that we understand this 3 versus 4 thing, because that's the real one that matters to most of the nephrologists. So what do I mean by posse-immune in the setting of lupus? That probably makes no sense to you because, again, you think about immune complex lupus. Well, we know immune complexes can be in the background mesangial with all lupus nephritis, okay? And this is an example of just a pure mesangial lesion, where you have a mesangial hypercellularity, and we have your immunofluorescence, which is positive for mesangial lupus, and it's most likely or most often in a full house. Okay, if you covered this up with your hand, this top lesion here in the middle, and you looked at just the bottom one, the immunofluorescence, you would notice that it's the same here, okay? So there, but you know then at the light microscopy level, you see this segmental destructive lesion, okay? So there's clearly something here which is not from the immune complexes, which is causing that. And this is really what we're talking about with lupus vasculitis. That's why it should be a different lesion. Contrast that to here, where you still have background mesangial, but you have these huge hyaline thrombi and also wire loops. And you can see them on immunofluorescence where you have your subendothelial deposits, okay? So we're just saying that both of these lesions can be very destructive, but they have very different immunofluorescence patterns. So including the IF, along with looking at what the H&E and the light microscopy really does help change what our focus should be. So if it was the WHO versus the ISNRPS, this would be a 2, this would be a 2. Okay, that's pretty easy. All right, if this was a WHO, this segmental necrotizing lesion, which doesn't have an immune complex mediated process for this destructive lesion, it just has background mesangial. Same thing here, destructive lesion. You could argue that only this hourglass portion here is the one that's uninvolved, which means that more than 50% of this tuft is involved, right? And if this would happen in more than 50% of the glomeruli, we would call this thing a 4 if it's the ISNRPS. but it's still a pauci-immune necrotizing lesion. This is just fibrinoid necrosis here. It doesn't mean that that's positive for immunofluorescence. Okay, so again, that's where the lumping came over. Okay, so this is the WHO4 and the IRSN 4G, where you have the immune complexes. Now, does it matter clinically? Well, if you define these lesions according to one's a lupus vasculitis, one is mesangial, and one is immune complex lesion, there actually are clinical differences. Now, we don't know if there's clinical differences in terms of joints and skin rash and pericardial effusion and a lot of the other systemic signs of lupus, but the serology actually has been shown to be subtly different. Mesangial, from a study that there's several studies that have looked at this. So there's our study at Rush, there's the collaborative study group, which is a national study of a whole bunch of different patients, which was also centered out of Rush, but a different patient population. And then there's Gary Hill's study, and there's a lot of data on what the complements and double-stranded DNAs are when you stratify these lesions according to one being a vasculitis, one being immune complex. So mesangial has the highest complements, although still abnormal, if normal is less than 80. If you look at the pauci-immune segmental necrotizing lesion, they do have slightly lower complements in the 3 studies, 60, 58, and 46. Okay, those are the different studies. But if you compare the immune complex one, where you're thinking immune aggregates are getting in there, they actually had less or lower complements. So 60 compared to 47, 50 compared to 58, 34 compared to 46. But on average, there was about a 12 to 15 lower C3 in the immune active ones compared to the pauci-immune one. Okay, so there's maybe some subtle serologic differences that you can find that might help you determine what the lesion is. And they also had a higher double-stranded DNA when it was tested. So this really is an immune complex mediated one systemically, serologically, and in the tissue. So here's the other features that are on the biopsy of the segmental one versus this diffuse proliferative one versus the mesangial one as a control. So the mesangial didn't have any of these severe variants, but there's background mesangial in all of these, which allows us to know that mesangial was a good control. But if you'll notice, there were a lot more wire loops and hyaline thrombi in the diffuse proliferative one as defined versus a lot less of those in the segmental one. And if you looked at the immunofluorescence microscopy for peripheral arteries IgG staining, where are the wire loops? The wire loops were a lot more frequent in 4, okay, and a lot less frequent in the severe segmentals. Also on EM, and this study was the only one that looked at EM out of Gary Hill and the Najafi paper, the only one that had EM, but had massive subendothelial deposits in the 4, but in the segmental necrotizing lesion, there were hardly any. Okay. There's another study, PAGNI, that I'm going to discuss here in a little bit that also confirmed these findings and took it one step further. Okay. So if you look at these studies, which have compared segmental versus global, it's not just a Rush thing. They've all shown that there's more wire loops and capillary hyaline thrombi in the global in all 4 of the studies. And those that had EM or IF, it also showed that the deposits were more subendothelial in these 2 studies. The trend is there. And then those that had fibrinoid necrosis were more likely to be the segmental ones. Again, just really showing, going back, relooking at your lupus cases, and it's consistent across several different patient populations. So where's the confusion? Well, again, they took what was an apples versus oranges, different pathogenesis, different fruits. You know, you may have a bigger orange here, or you may have a smaller apple, but they decided to take these apples and put it in here and make it a very strange tree. Okay. Now, this Paganini study, they took it one step further. So it was a great study. I think there were about 140 lupus biopsies, and that also had a second biopsy. So they called the second biopsy RB, a rebiopsy. Okay. So at the first biopsy, they had all the classes represented. And what they said is, we're going to look at what happens when we rebiopsy them. And the rebiopsy was for a clinical indication. It was a retrospective study. And the rebiopsy was possibly for a change in clinical status, or the rebiopsy was also because they wanted to see if they could wean immunosuppression sometimes. So there's a lot of reasons to need a rebiopsy in lupus, and they included all the ones that had it, okay? So, but what they noticed was at the first biopsy, if you had a mesangial lupus or 2, that's over here, at the rebiopsy, you either had a mesangial lupus again, or you had this wire loop lesion. You very, very rarely, one actually out of all of them, had a segmental lesion. Okay? If you looked at the segmental lesions at biopsy at first time, okay, here. At rebiopsy, they were almost always a segmental lesion still. Very rarely did they transform into an immune complex lesion. Okay, so what that means is it's very, it looks like the mesangial may actually progress to a diffuse proliferative if it's untreated, but very rarely does it go from a 2 to a 3 to a 4. And that kind of shows that this 3 lesion is really something completely separate, because on rebiopsy, you almost never switch classes to the pauciimmune lesion. Okay, so they also categorized their lesions the same way that Hill did, that Najafi did, and that we did, and they noticed the exact same thing with the light microscopy and immunofluorescence features. But they also had this rebiopsy data, which really, really points towards the pathogenesis of this being a different lesion. So if it is such a different lesion, and it is so crazy, and it has been ignored, we hopefully will include this in the future, but why is it happening? I think the obvious, elephant in the room is ANCA, right? We've got the segmental necrotizing lesion. It's got to be ANCA-associated nephritis. So in our data, we didn't have a lot of ANCA on everybody, but we might have had in our segmentals, we had maybe 80% of the patients had an ANCA tested. And then diffuse proliferative patients, we had 50% of the patients were tested, and we had 1 positive ANCA in each. So that's not very convincing that it's ANCA, and there wasn't a difference in the ANCA, but this is hardly a huge population to look at ANCA. And so those actually exist. This was Nasser's paper looking at the pauciimmune lesion and if it is due to ANCA. And what they found is that about 18 to 20% of patients who have lupus also have a positive ANCA, okay? And they had certain features on light microscopy and immunofluorescence that were more consistent with an ANCA vasculitis. We've seen several case reports of ANCA and lupus, okay, where you have the segmental necrotizing lesion, but we also know that the segmental necrotizing lesion can exist independent of ANCA. So the best study that really looked at this was with Liz Lightstone and Pusey from the UK, and they looked at all their patients who had a positive ANCA and who had lupus nephritis. They again found it was about 20%. But what they did is they really defined the histologic and serologic activity on all these patients, okay? And so if you look here, and again, they're classifying this according to the ISN RPS classification, where we have 4S is the severe segmental, 4G is the global, and class 3 is always, again, almost always segmental, but it's just less than 50% of glomerular involved. So those that were ANCA positive were black. Those that are ANCA negative are white. And what you notice was the segmental lesion was often, statistically significantly, more often ANCA positive. However, we still had some ANCA negative patients in that patient population. Okay, there was not a difference in the 4 globals, although ANCA was a little bit less. Okay, and if over here, if you classified them by segmental versus global, you found out that there was a big difference in ANCA positivity, but there's also a certain amount of patients that had a segmental lesion that were negative for ANCA. So the point is that yes, ANCA certainly is associated with these segmental necrotizing features, but that's not the only reason in lupus nephritis that you can have a segmental necrotizing lesion. And it's the same thing with necrosis and also with crescents. So with all of that, knowing that there's this different lesion, how is the classification currently going to change? What are we going to see for the next iteration of the classification? And we don't know yet. It's not out yet, right? But there's some hints in that they've published along the way for the ISN RPS societies that published some classification changes along the way. And this was their most recent one, which is about 6 years ago. And they wanted to define things a little bit more succinctly. And they're going to put definitions of endocapillary proliferation and not use that term anymore and go more towards hypercellularity. I think that sounds great. They said that because there was no definition of fibrinoid necrosis before, they're actually going to include fibrinoid necrosis in the new classification. I was like, yes, this is what we've been waiting for. We need fibrinoid necrosis to be included in the classification. That's the segmental lesion. That's number 3. That's lupus nephritis vasculitis. Okay, great. So I was like, stoked. This is great. And then they're going to eliminate this whole global and segmental divisions in class 3 and 4 because no one likes it. And also, fantastic. So I love that idea. Just there's no reason to start counting glomeruli when the pathogenesis is what should be driving it. So here's their proposed revisions. I'm going to move my little Zoom screen out so I can see the whole slide here. And just some definitions. We've got our podocyte out here in light green. We've got our endothelial cell in yellow. Our mesangial cells are red. When these big black things come in, those are our deposits. Okay, so they're saying that a class 2 is going to be mesangial lupus. They're also saying class 1 is mesangial. And so I've got thoughts on mesangial lupus, but I'm not going to get into that now. I don't think you should have a severity, just have one. But so then they have a class 3/4, and then they have another class 3/4. So this already doesn't make much sense to me because why would you have 2 classes that are different, but then they're named the same? But notice here, the class 3 and 4 has subendothelial deposits. And this class 3 and 4 has subendothelial deposits. The only real difference is that there's this infiltrating leukocyte in this one, and there's not here. So this sort of really bothers me because this really should be the quasi-immune no subendothelial deposit lesion, and this one should be the subendothelial deposit lesion. If we're going to really recognize fibrinoid necrosis, we should be giving it its own class, and that should be the quasi-immune destructive lesion, and that can have mesangial deposits, but should not have these subendothelial ones. So we say this is the wire loop lesion 4, this is the vasculitis lesion 3. That's how I think it should be. And then you can have some mixed lesions, of course, and then we have our mesangial over here. So I was very excited when I read the text, and then I got a little upset when I was looking at the, but this isn't about making me happy, of course. Although I thought that's what the world was here for, to make me happy. What did they kind of, I think, miss? Well, fibrinoid necrosis, all they said they were going to represent it is really not represented. Class 3 and 4, the same class, except for this cell difference. And to me, that's like lumping TTP and HUS together. Remember in the 1990s, the trainees may not know this, but TTP and HUS were considered to be the same disease for a long time. And my God, if you're practicing now, you keep those about as separate and far away as possible, right? They're completely different pathogenesis and they're treated differently, right? And so that's my same point here is that we're going back to the 90s here with this sort of lumping of pathogenesis together. So both class 3 and 4 have wire loops. We don't like that. Nowhere is the immunofluorescence included. They're still heavy on the light microscopy. But if you saw here with no wire loops and you saw the immunofluorescence with just the mesangial, but you'd still have almost a crescent, it would be obvious that that's a vasculitic lesion. And then you would see all these wire loops very strongly and intensely on the immunofluorescence here. And then the electron microscopy is really for the inclusion of the podocyte and that podocytopathy, which I don't think we'll have time to get to today, but I think that needs to be included as well. So that's how I think the classification should change. Let's just make, I think mesangial should be one class. I think the next class should be a segmental necrotizing lesion, the lupus vasculitis lesion. The next one should be a wire loop lesion or an immune complex lesion. And class 5 should be, or the next class should be membranous. And of course, there's mixed classes along the way, okay? So I wrote about this in an editorial and where I just said, focusing again on the 3 and the 4, 3 should be our vasculitis and 4 should be our immune complex, and we can keep it very separate and easy. Knowing that calling it post-immune is a little tricky to most people because the background mesangial deposits are still there. But if we call it a lupus vasculitis, that might kind of help get around that, similar to the way we're now defining an IgA vasculitis. There's background mesangial deposits of IgA in that one, right? So hopefully this makes sense. So often on the immunofluorescence, this will be pauciimmune. It may have positive fibrin in the background, and this is always going to have these subendothelial wire loop deposits. Okay. And I think including podocytopathy is important too. Okay. So I think I may have time to go through podocytopathy, but I'll try to keep that brief. My main point here is that I think that podocytopathy should really be included as it's either presence with diffuse foot process effacement or absence in every single class and in every single report. And I'll tell you why. Originally, podocytopathy was coined by my predecessor, Ed Lewis, and who noticed in the first sort of large cohort series here that there was this whole nephrotic syndrome patient that existed, but on biopsy, in the setting of lupus, but on biopsy, the only real pathogenesis besides maybe background mesangial was either a segmental scar looking like focal sclerosis with diffuse foot process effacement, or no abnormalities looking like minimal change. And because the two of them didn't seem to coexist as rare diseases, they thought that it's very likely that there's some pathogenesis here from lupus, which is attacking the podocyte, causing its fusion. And so the term podocytopathy arose. Ed Lewis said before he died that he always wanted to have podocytopathy in the dictionary and have a little star that he was the one that named it, but I don't think Webster's ever really responded to him. So with some other data that we looked at, we found that podocytopathy can exist independent of normal glomeruli, and it also exists if you have foot process effacement with background mesangial. And we even looked at it in membranous, which you think, okay, well, membranous has got the GBM deposits, right? It's not really a foot process issue, but we noticed the nephrotic patients with membranous also had diffuse foot process effacement, okay? And then another series looked at a large cohort that showed the degree of proteinuria, and no matter what your lupus nephritis class was, correlated with foot process effacement more so than the immune complexes. And that was our point of the membranous one here, that the pathogenesis of membranous and proteinuria is really in the podocyte, not in your GBM. And it's the same thing for all the classes. So if you have a 4 or a 3, you may not have that much proteinuria if your foot processes are intact, but you're more likely to have a lot of proteinuria, even if it's a 4 or 3, if you also have diffuse foot process effacement. So commenting on that, I think, is important because that also drives at the pathogenesis. We might, in the future, be able to attack that cell, right, the podocyte itself, stabilize it, and hopefully help the patients get better, right? And so they've actually looked at correlation of all the different classes and proliferative and membranous and in overall lupus nephritis and all the combined ones. And they found out that there was a correlation between proteinuria and foot process width. Now, why? Just like why segmental necrotizing? Is it ANCA? Yes, in some, not in all. So, you know, the world is exploding on podocyte energy right now, especially with nephrin. And I don't know, maybe nephrin's also more likely to be diffuse foot process effacement in lupus. But if we don't include that there's foot process effacement, we're never going to figure out what the problem is, right? We're never going to figure out that there's an injury there, and that's the cause of the proteinuria, and maybe stabilizing that is helpful. So we really need to, you know, maybe people who have lupus nephritis have their double-stranded DNA, but they also have nephrin antibodies. Maybe we need to attack that differently. And so it really does need to be included in the classification. And in the current classification, the way it's going, they are going to include podocytopathy. I don't know if it's going to be a separate class or whatever, but I think the way I would see it is that podocytopathy should be included in every single class, whether it's there as diffuse foot process effacement or not. And then we'll be able to study it more, see if it really is correlated on a prospective manner with proteinuria. Now, what if you've got membranous, but you've got a segmental necrotizing lesion? This is very, very common. We all know of this. We see membranous with segmental necrosis in lupus all the time. We call that an overlap case. You may have seen somebody say that's a 5 and a 3. That's a 5 and a 3A if it's 3 active, right? Good. So we know overlap cases exist, okay? What if you actually have a segmental necrotizing lesion, but you also have a wire loop? That doesn't make any sense according to what I've just talked about. Let's keep it separate. Wire loop over here, vasculitis over here. Well, why can't you have 2? And that would be an overlap of an immune complex lesion, wire loop, and a vasculitic lesion. And so that one, you would be a 3 and a 4, just like you have a 5 and a 3. Okay, so lupus is complicated, right? It's not always going to be the exact same pathogenesis. It's not always going to be ANCA for your segmental necrotizing lesions. You can have lupus that's rip-roaring and have normal complements and normal double-stranded DNA. Most often it's a membranous. So it's complicated, but if we don't start to organize it the right way, we're never going to uncomplicate it. So why does it matter? I think I've hopefully made a point for all this, but in the future, it'd be great to see if we could really treat lupus similar to the way we treat MPGN now, which is targeted at the cause. So I think very simply, after all of this, and you may be confused because I said, oh, some's post-immune and all this kind of stuff. The real way to make it simple is just make sure that immunofluorescence is included. We'll see that there's a post-immune lesion, except for background mesangial, with a segmental necrotizing necrosis, with possibly crescents. We'll see the wire loops greater there, okay? That will keep those separate. And we need the EM to include podocytopathy in all the classes. So this is my plea, which is, let's just make this and call it lupus vasculitis. That's very simple. I think anybody can understand that. And hopefully I've shown you that, not just because I want to hold on to the past, but I've shown you that with data that actually matters. So I think maybe I'll stop there and take some questions. And this is a picture of Ed Lewis, who passed away about a year ago.
Thank you. That was very persuasive storytelling. I'm not a lupus expert, but I'm persuaded by the lupus vasculitis as well as the podocytopathy story. We have GN folks in the conference room as well as our nephropathologist. So I'm opening it up to questions from them while they're thinking about what to ask. Can I ask something else? So
Sure.
there are all these trials of lupus nephritis. They also have biopsy data. Has anyone looked at whether this matters from that perspective? Again, I'm not familiar with the literature, so I'm asking.
That's right. I think what we need to do to really hammer this point home is take the ALM study, biopsy, and get those that actually had pathology and not just a report, go back and reclassify them, and then see if there's a treatment effect. I think that could be a nice retrospective next step. And I think also, hopefully, reclassifying it in this way anyway in the future will make it a lot easier for the future classifications to go to see if there is a class effect. Because right now, the way that it's classified, it's too mixed up, and there'll never be a class effect. There's 4 people that have already done it, right? There's 4 different patient populations that have already done it that I've shared with you. But yes, I think the more it could be done, the more it will show, or maybe it won't. I mean, that's science, right?
Exactly. Yeah, conference room, Mark or David?
Yeah, as well as Mark first. Thanks, Dr. Whittier. That was a really interesting talk. I think you've pretty much convinced me. Just in the last week, we've had a really tough case of a young kid who we rebiopsied, and the dominant lesion is really a segmental fibrinoid necrosis, and he's proving pretty stubborn to treatment. And Todd, I think Todd is on the call as well. We were just saying that, you look at that classification system and you get a new class 4 with that much chronicity. I think we're actually more hopeful about starting treatment in that person than we are with the class 3. Maybe that speaks to your point. But I wonder whether you could tell us whether, this concept has changed your initial approach to therapy. So for example, if you've got more immune complex deposition with or without podocytopathy, do you bring the CNI in as a multi-target therapy straight away? If you've got more of a vasculitic lesion, do you reach for cyclophosphamide? Do you sometimes use rituximab versus going to MMF and finding out 6 months later this isn't really working? So just wondering whether it's changed your approach to the initial induction.
Yeah, thanks for that question. I would say based on data, we have no idea. I can't say based on data that we know that one treatment regimen is better than the other. Okay, so we're in the opinion realm. The reason a lot of this came up was the Najafi paper, which, as defined in a very specific population that was a randomized controlled trial where they are all treated the same with cyclophosphamide, they noticed that the segmental lesions actually had a poorer prognosis. Okay. And the cyclophosphamide treatment that the collaborative study group used at that time was 2 months of oral Cytoxan, okay? And we think it wasn't like the TM Chan 2 years of oral Cytoxan compared to MMF that was in the New England Journal. It was just 2 months of oral Cytoxan. And because the prognosis was worse than the segmentals, that came up with the idea of, gosh, maybe we're not treating them long enough, or maybe we need to treat them with something different. Maybe we do need to treat them more like a vasculitis. Maybe they need longer cyclophosphamide, because that was the thought process at the time, that the old Wegners needed a long amount of cyclophosphamide, but the other ones didn't, right? And so that's what sort of stimulated a lot of this whole hullabaloo about the segmental lesion anyway. So we do think that there may be enough pathogenic differences to treat them differently. And as far as Rituxan and lupus, it's unfortunately gotten a really bad rep. The LUNAR trial did not help because, great trial, right? But they used rituximab as add-on to MMF versus MF alone, and it was an unsuccessful trial. But when you look at the follow-up study where those that got B-cell depleted by Rituxan, it was actually a successful trial. So I still think that there's really a lot of hope for B-cell depletion. And certainly when you look at the new OB data, obitunumab, I'm sure I got that one wrong, but the new OB data shows a lot of success with B-cell depletion. So I think that we're going to hopefully have a lot more information. But again, if we don't classify it correctly, we'll be treating everybody the same with OB in the future or CellCept, or we're not going to be able to know how to pick one differently or the other. And that's my whole point of this. But yeah, I reach to Rituxan or B-cell depletion quite often in lupus. I don't think it's as dead as the literature would suggest. With the newer agents, Benlysta, voclosporin, it's hard to tell if there's going to be a class effect or not.
Thank you. I think in fairness, with our current rates of, good remission, I think we're justified to kind of be in opinions on sometimes. David has a question as well.
Yeah, thanks very much for the talk. I just question, I noticed you didn't mention anything about activity index, chronicity index. Is it something that is not reported at your center commonly? Is it because it doesn't really, not felt to really, I guess, have any prognostic value? Because it would take into account those, I mean, that falls into the activity index, those lesions of fibrinoid necrosis, if I'm not mistaken. But just wanted to get your thoughts on that.
I think if it's a fibrinoid necrosis can then become a segmental scar, right? And so I think there's a scarring component and there's an activity component. I think that is still important to know as a nephrologist. I just don't think that the scarring necessarily gets at the actual pathogenesis, and that's what I was focusing on today. But yeah, certainly if someone's got 90% scarred and global sclerosis and their creatinine's 4, and that tells me a lot of information that we can pair up histologic features with, when is it time to give up on how aggressively we're going to be at treating, knowing that this person may need a transplant in the future and may need years of immunosuppression. Are we harming them by giving too much? And so I actually like having those there because they give me some information. I'm always looking at the biopsy myself with my own eyes and assessing the chronicities. And I know that there's an index score, and I don't really know that score very well because we're always just kind of looking at how much tubular interstitial fibrosis and scarring there is, how much global sclerosis there is. But that's really just to justify any treatment in my mind, not necessarily justify which treatment. And today's talk was sort of more geared at which treatment based on pathogenesis. And so that's why I didn't go into it as much today.
All right, thank you.
Thank you. If there are any other questions, please speak up. If not, I'll go again. So the point you made about classification and staging is again very persuasive. It's sort of like the CKD staging as well, where people think it's a progression where it may not be. What is stopping the these societies, ISN, WHO, RPS from taking this up, right? Is that sometimes these societies make, do you have any sense, again, I'm asking you to speculate, do you have any sense why they are not going in that direction? Sometimes these decisions are made from pragmatic perspective. I had heard in the past that, internationally, not everyone may have access to IF and so on and so forth. I don't think that's true anymore, but do you have a sense why they are staying away from IF, or is that just, dogmatic way of thinking?
Yeah, that's why I put this publication out, and that's why I'm getting grand rounds, and I'm trying to get more awareness out there about this vasculitic lesion. My partner, Pravir Baxi, is from Detroit, and I recently at GlomCon was able to ask Agnes Fogo kind of about this issue. So the reason I mentioned Pravir is because I had one shot, opportunity knocks. I was going to take that one shot, right? And so I asked her, I just said, I talked to her she was at the podium talking about the classification changes. So I thought it was a nice, perfect time to have a conversation about what we should do. And should we include the immunofluorescence the way Sethi did? And we talked about it. And she said that she said she didn't think that the society was ready for that much change. That was number one. Meaning I was almost saying, let's just get rid of the numbers. Why do we need 1 through 6? Why do we need any of this stuff? Why can't we have a mesangial, a vasculitic, a wire loop, and a membranous? Like, does the MPGN have a number? Do we need to have all these numbers? Do we have that in vasculitis? Do we have that in IgA? And that's also pointing people down the road of thinking it's a staging system. If 6 sounds worse than 1, but so why have a number at all? And then the second was including immunofluorescence because that drives at the pathogenesis. And she said, well, with the MPGN pattern of injury, the immunofluorescence was coming from different disease states, which is true. And so she said that that's not the same in lupus. They're all coming from lupus. But my point was these are different pathogenesis, almost as if they are different disease states, right? That we can have a vasculitic type lesion in lupus and an immune complex lesion in lupus. And so I don't know if I convinced her, but I hope I can keep working at plugging away and hopefully even be invited to some of the meetings so that we can make sure that we're all on the same page for the future.
Sounds good. Any other questions from the audience? I know. Yeah, Roger, go ahead.
I remember back, this was after the collaborative study group plasmapheresis trial. Mel Schwartz and Ed Lewis put together an evaluation, getting back to the chronicity and activity indexes. This is a paper from AJKD in 1993, a long time ago, but they've actually sent all the slides to a number of pathologists to see the agreement on activity and chronicity index, and it was very poor, which is not surprising. It's because there's a lot of subjectivity, and I think that's one of the limitations of it. And I think what Bill said is what's we've been taught to do, and there's nothing like your own eye test. You go in there and look at it, you can say this looks pretty awful, or this is pretty salvageable. And what was also brought up, I think I've always been a firm believer in that the worst proliferative DPGN is probably a better lesion to have than the mildest segmental necrosis, because it's kind of like a post-strep GN. It kind of you feel like it can melt away. There isn't always that much tuft sclerosis or destruction that would lead to sclerosis. So I think that was kind of brought up earlier by the discussants. Bill, what about complement blockade? Is that for lupus nephritis? If you're thinking about a vasculitic lesion, what about a complement blockade?
Yeah, I skipped over my disclosures, but I'm actually involved in a lupus nephritis complement blockade study right now with Novartis. And so the answer right now is we don't know, but I am very hopeful. And anything we can do to minimize steroids, right? I mean, these poor, most often women that get these steroids, steroids aren't great for anybody, right? But man, it can be a really destructive on your body, although it is life-saving. But if we can get a steroid-free protocol or something with complement blockade to show that it works like avacopan and vasculitis, I think that'd be the future. So ongoing study, the answer is we don't know.
Well, it's interesting, because avacopan is it's steroid sparing, but it's really, to me, it's as much about pathophysiology as anything. And, that's the way the study was designed. But you have to wonder if this is really a different pathophysiology and maybe complement mediated, that it's not just about steroid sparing, and maybe about a better way to, target the pathophysiology as opposed to what we've done in the past with at least cyclophosphamide. And that's just, knock out the whole immune system and pray we don't kill the patient.
Yeah, I think there's a lot of hope for specific therapies in the future, and I would love it if there was hope for specific therapies for a specific class, because I think it's really different diseases that we're dealing with here, and that's my point. I'm not sure I'll get there, but yep.
No, I'm sorry, Bill. The problem is that it's not like you can do an IgA study where you have 2 patients. It's really tough to get even a couple hundred bad lupus nephritis patients. And then if you're going to break down the subset into a paucity immune or a DPGN to determine what's the better therapy, I don't think it'll ever be done.
Yeah,
So,
parsing them is going to lose power.
We're always left with what yeah. Never be power to do that. So kind of we're left with what maybe we kind of believe or hope to believe, but that doesn't mean we don't try.
Certainly the way it's
obviously.
classified now, it's not going to help anything. And that's my point. It may be that it doesn't in the future either, but let's at least start at the right spot so that in the future, if there is a difference, we'll know that. And this is a very simple pathogenesis or a simple classification to wrap your head around. It's not that complicated.
I have a quick comment. Can everyone hear me? Sorry.
Yeah. Go ahead.
This is Pravir. Yeah. So of course, Eminem in Detroit was provoked. So now I have to say something. Joking aside, it's just more of a comment. I kind of along to what Bill is saying. Every time you read about lupus or anything, it's a spectrum disease. There's lupus spectrum of manifestations. So I don't understand why we, as Bill is trying to highlight, is there's a spectrum of kidney manifestations. There's a spectrum of diseases and of how lupus affects the kidney. I think that's what he's. I don't understand why we can't get that across. It's very interesting, and it's. We think about it, we write about it in textbooks, we read it, but then when it comes to it, we're not looking at the different maybe pathogenic mechanisms of how lupus affects the kids.
Yeah, great point. The conference room wants to make a final question. If you have time to stay on, Bill.
I do. Thank you. Yeah.
Well, it's just Bill, it's Mark again, just building on what Dr. Rodby said there. I mean, yes, we have a much better sense of targeted therapies for let's say IgA nephropathy, but then it makes no sense to me then that you would enroll people in a trial who have proteinuria above X and a history of a biopsy in the last 3 years. We're not trying to find any kind of molecular signature of what's the underlying driver. Would this person be better suited to a B-cell therapy versus a complement therapy? So it's there's a real mismatch between all these great discoveries about underlying mechanism and then what we actually bring into a trial and then wonder why we don't get the answer we want. So I'd be worried that the same thing will actually, happen here. But I do agree the first step is to just, get everybody on the same page. So
yeah, and I don't think that we need to necessarily enroll people in a trial and just include the vasculitic ones. I still think we enroll all of them in the trial.
No, for sure. But you could do something like they did in testing, like to stratify on the E1. Maybe you just want to learn by stratifying on that lesion just to get some better understanding, right? So
absolutely.
Fantastic. So I was going to make the same point that Mark made a little bit more eloquently, perhaps. But this just opens up our eyes to how we should be. I hope the classification changes, but I really hope that these kind of discoveries and thoughts are taken into account for future clinical trials. So thanks again to Bill and for the the rest of the crew from Rush who joined. Pravir has added his email in the chat for those who would like to join their phenomenal renal biopsy rounds with a wheel that I would encourage you to check out. And I hope to meet some of you next week at San Diego. For the rest of the crew, we take a break because of ASN, and we'll be back in early November with Adnan Sharif talking on cardiovascular testing in CKD. Thanks, Bill.
Thanks so much.